Good morning and welcome to Healthcare Innovation's Mid-Atlantic Virtual Summit. My name is Matthew Rayner. I'm the publisher here at Healthcare Innovation. We are so excited for this week's program. As I'm sure you are all aware, this event typically takes place in person in Philadelphia every year. And though we wish we could all be in person, we are absolutely thrilled at the wonderful content we have laid out over the next few days, designed specifically for healthcare leaders in the Mid-Atlantic region of the country. Whether you are consuming this content live with us here today or watching on demand, thank you for being a part of this program. I would like to give a big thanks to our faculty that we have lined up here at the virtual summit, and also a very big thank you to our supporters at Caroline and Nutanix for making this program possible. We encourage you to learn more about our supporters by visiting the virtual booth section within the event platform's website. You'll notice that we have some wonderful educational content from our supporting partners shared there, as well as some contact information if you are interested in learning more. A very quick housekeeping note to help you along this week if you are choosing to watch this content live. All of these sessions are designed to be interactive. We want to hear from you. If you have a question for our faculty at any point this week, please don't be shy. Submit it through the chat box. We will do our very best to get through as many of your questions as we possibly can throughout the sessions this week. As mentioned, we have some wonderful sessions planned for the next few days, and I would love to, at this time now, officially kick off the Mid-Atlantic Virtual Summit with our opening session, which is a two-parter, an opening discussion and then an opening panel discussion. Part one of this opening session is a conversation with UPMC Central PA about diversity, equity, and inclusion. Joining us is Tina Nixon, who is the Vice President, Mission Effectiveness, Diversity, and Inclusion with UPMC Central PA. With that said, I would love to welcome Tina on to help us kick off this Mid-Atlantic virtual program. Tina, thank you for joining us. Tina, you are on mute.
As usual.
There we go.
Good morning, David. Thank you so much for inviting me. I'm excited to be here with you this morning, and on behalf of the executive leadership team at UPMC in Central PA, it's an honor and a privilege to be a part of this event. And just to let you know that we are a part of UPMC overall, but we're not based in Pittsburgh. UPMC in Central PA includes 7 acute care hospitals with 1,160 licensed beds, over 160 outpatient clinics and ancillary facilities, more than 2,900 physicians and allied health professionals, and approximately 11,000 employees. It is the healthcare hub serving Dauphin, Cumberland, Perry, York, Lancaster, Lebanon, Juniata, Franklin, Adams, and parts of Snyder County. So I just wanted to let you know where we are. And I am based in Harrisburg, Pennsylvania.
Excellent. Thank you, Tina. I was wondering, and I think the audience is wondering as well, if you could maybe start this conversation off by telling us a little bit more about yourself and your role within UPMC Central PA.
Absolutely. I'm new to healthcare. I've been in healthcare for about 6 years now. Prior to that, I was the CEO of the YWC of Greater Harrisburg. My job duties as Vice President of Mission Effectiveness, Diversity, Equity, and Inclusion really entails the oversight of a lot of our community-based programs. I oversee our spiritual coach services, our volunteer services, as well as our community health clinic that has integrated one-stop shop of a HIV/AIDS clinic, a opioid treatment clinic, and with a wraparound specialty clinics that we provide the community. Very excited to be in this role to be able to connect the dots with diversity, equity, inclusion, health disparities, and health equity. I know individuals over the past year have been hearing a lot about the disparities, but I have to say this is something that we've been working on for quite some time. And this role is twofold. I support not only internally staff and physicians and leadership, but also I support externally our community, and especially those in our community that have barriers to accessing quality healthcare.
Excellent. You mentioned the internal and the external. Working on diversity and inclusion, where would you say that fits within the organization? Who all within the organization do you find you're collaborating with the most?
I would say everyone at every level. It's very important when in doing this work that you have engaged leaders at all level. I can say our senior most leader, Phil Garnishelli, is completely engaged and supportive of the work that I do around diversity, equity, and inclusion, as well as our frontline staff and our environmental staff in providing support. I think it's important that people understand in doing this work, it's not one person's job, it's everyone's job. And you really have to be able, as they say, walk the walk and talk the talk. And by doing that, it's really having everyone that's on your team all moving in the same direction and understanding where you're moving when it comes to doing this work.
Excellent. Thank you. Can you maybe expand a little bit about UPMC Central PA's initiatives when it comes to diversity and inclusion?
Absolutely. From my service line area and the things that I work on a regular basis is really looking at when it comes to the community piece, individuals, like I said, that have barriers and how we go about addressing those barriers and looking at data to make sure the work that we're doing is supported by the data. So I call my team the boots on the ground team. We will go to underneath the bridges to provide COVID vaccine testing. We will go underneath the bridges to do follow-up visits for individuals that were just released from the emergency room. We go to homeless shelters, senior living facilities. We have a home visit program as well as other wraparound services. I feel that our work is really meeting people where they are instead of having them come into the hospital, which we know that for some folks it's trying, especially with transportation and mobility and those type of things. So really some of the work that we do is truly trying to get what the patient needs where the patient needs it.
No, that makes sense. So, and you touched on this a little bit just now, but I'm curious, what are some of the challenges when it comes to building partnerships, building trust between a big, massive health system and neighborhood groups and community-based organizations? What are those challenges you're dealing with?
So one of the things I always say, people come into communities and from my career experience with wonderful programs and they come and go and they come with evidence-based programs that are supported by grant funding, and they're wonderful creative programs addressing the needs of the community, but they don't figure out how important it is to sustain some of the programs that are developed. And I think it's important that the trust that you build, people have to know that you're going to show up and show up all the time and be there, not only in the good times, but again, in those critical times of need. And so it's not so much about trusting the brand, but trusting the individuals that are doing the work and making sure that you're out and about and they see you. My kids always used to joke when we would go to the grocery store, Mom talked to 25 people at the grocery store. And it's because I'm a part of this community and I care about this community. And so it's important that people see individuals that are committed and trusting and that will respond. And the programs that you create are sustainable and making that connection. You know, we talk about community health workers. I would say my mother was a community health worker before that title was even invented, and she started the first soup kitchen in our community, and providing those who you were hungry with food. And so I think being a trusted member and integrated in the community is very important from my perspective.
Absolutely. So my final question, I think, before we shift our attention over to the more panel discussion format, if you don't mind, maybe getting out that crystal ball a little bit, what would you say the next few years, the next 2, 3, 5 years look like, not only for your role, but for UPMC Central PA's overall mission when it comes to diversity and inclusion?
If I had a crystal ball, the next 2 or 3 years would look like what we're doing now on a grander scale. Again, using the technology and the resources and the subject matter experts we have to really go out and meet the needs and really change some of the things that we've been doing. Over, for years and years and years, a little differently. COVID shined that light on those health disparities. And for some of us, we've been working in this area for a long, long time and addressing these issues. Now that we have this big spotlight, utilize the resources that you have to effectively change the dynamics of the way people receive healthcare, the way people are living, truly addressing those social determinants of health, and not just by putting a Band-Aid on them. So I think, if 2 to 3 years from now, instead of, people seeking out where to go and what to do, we are out there providing that support on a regular basis and helping them no matter where they are in their life. As I mentioned, if they live under a bridge, if they live in homeless shelters, we should be out there really addressing their needs as it relates to healthcare, because we found the data shows, it's cost effective when someone doesn't utilize the emergency room over and over again as their primary care place. So we need to make sure that we are creative and innovative and using the technology that has already been developed to really monitor and address some of the needs of our communities.
Excellent. Thank you, Tina, for this fantastic opening conversation. I would now love to welcome in our panelists who will be joining Tina for our opening panel discussion, Health Equity Takes Center Stage. Moderating this opening panel discussion is our senior editor, David Raths. David, take it away.
Thanks, Matt. Over the past few years, I've gotten a chance to write articles about health system strategies designed to address racial and ethnic disparities, and including having the opportunity to interview 2 of the people on our panel today. So you've already had a chance to meet Tina from UPMC. Let me introduce our other 2 panelists. Aswita Tan-McGrory is director of the Disparities Solutions Center at Massachusetts General Hospital in Boston, where she leads a portfolio of projects focused on addressing racial and ethnic disparities in healthcare. And we also have Dr. Jaya Asola, the Assistant Dean of Inclusion and Diversity at the Perelman School of Medicine and founder and executive director of Penn Medicine's Center for Health Equity Advancement. Even though I've just given your titles, maybe we could have Aswita and Jaya give us a little more detail about your roles and the work you do. Why don't we start with Jaya first, and then we'll go to Aswita.
Thank you, David. It's a pleasure to be here with all of you this morning. Again, my name is Jaya Sola. I'm the executive director of the Penn Medicine Center for Health Equity Advancement, which is sort of uniquely situated in the C-suite of a multi-hospital system, large academic center, and it's affiliated with 4 health sciences schools and 7 hospitals. And I run the operations for equity, inclusion, and diversity for Penn Medicine's health system. And through that, we're just bringing to the front line of care delivery, the science of equity. I'm an internist and pediatrician by training, and I have a master's in public health and healthcare policy and management with an equity lens. And so that's what we bring to this.
Okay. Aswita.
Oh, thank you, David. And thank you for inviting me to be on this panel. I'm Aswita Tamagori. I'm the director of the Disparity Solution Center at Mass General Hospital. You can see Boston in the background. And that's downtown Boston. And what our center does, it's been around for about 17 years now. And we really focus on equity in clinical care and specifically racial equity in clinical care. And so we've just had an opportunity to both work internally at Mass General Hospital, but also externally working nationally and internationally with healthcare organizations who are interested in learning how they can address disparities within their own institution. So it's sort of been great to both, try things at home, but then also connect with other folks and sort of collaboratively learn like what works, what doesn't, what are the things that we need to think about, and sort of what are the challenges that we see nationally. So we have a very good sort of finger on the pulse about what's happening across the nation.
Great. Well, we'll delve into some of that in this conversation. I thought maybe we could start by talking about the impact of the pandemic. And I have kind of a two-pronged question. First, how has the pandemic highlighted ways in which the health system does not really work well for everyone? And second, did the pandemic was it a test for how nimble health systems are in mounting a response that accounts for health disparities? Anyone want to start off on that?
I can start because we were in Boston during the surge, and actually something popped up on my social media the other day where it was a picture of myself and my family eating out after a 3-month lockdown. And I remember thinking, oh, was it 3 months? God, it seemed like a long time, right? But we were in the midst of a surge last April, probably through the beginning of the summer, and we learned a lot. We learned a lot about, well, I'll tell you the key things that we learned just to take away. I was on the team across Mass General Brigham, which is the larger healthcare system under which the hospitals sit, that looked at equity in COVID and making sure that we weren't, increasing the disparities with any of the mitigation strategies and later the vaccine rollout. And one thing we learned is that, virtual care, which ended up being where we moved towards, really had some challenges. And I saw a question here, what is the role of technology to address social determinants of health? There were a lot of challenges for people to access virtual care. I mean, if you think about what it requires, private space, the ability to have broadband, the ability to have Wi-Fi, the ability to have the technology, the ability to navigate it. There was a lot of issues there. And then the second piece that we learned is that integrating interpreters seamlessly into our care delivery is important. And if we don't do that, it'll come out in our outcomes. And so we saw that when over 50% of our patients were coming from immigrant communities like Chelsea and Revere, and they needed an interpreter. And so we realized that our systems weren't working as well for those patients. And the other piece that we learned is that trust, like Tina mentioned, trust is important in the community. And so this really will test how trusting the community is of your organization. You might have a perspective of how well you're doing the job, but unless you ask community members and you're present, there may be a different perspective externally. So we really learned a lot about how to cooperate with the community, and I think we've been fairly successful. I think there's lessons learned, but I think we've been fairly successful. And the last thing I would just say, like, privacy is a big thing. And this is wrapped around also with immigrant concerns and immigration concerns. There was a lot of rhetoric going around about ICE and ICE visits during this time last year. And so we had to really address those issues, and people were reluctant to download new apps on their phone because they were afraid about what we would do with the information. So those were sort of like the things that we learned.
Jaya, do you have some ideas what's been learned in Philly?
Yes, at Penn. I really like this question for two reasons. The second half of it, in terms of how nimble we can be, we always talk about sort of necessity being the mother of innovation. And you sort of saw that, we saw that at least at Penn, where, we sprung together to create really creative programming at a time where there was dire needs. And we saw the health system really respond to the evolving and changing needs in flux of their communities. So I think in those ways, it was really something we should carry forward. One of the things that Ashwita talked about in terms of telemedicine, I think, it's interesting. There are barriers to that, but what I also found was, as someone who's sort of, again, similar to all the panelists, just thinking about equity all the time, what telemedicine or telephonic care delivery can do in terms of mitigating barriers to access to care as well, in terms of, eliminating the need to get childcare for your family, to do a telemedicine, to get time off work or unpaid leave to come see the doctor. I, as a tele-first medicine primary care provider, I conducted a multitude of visits where people were at their job still and still able to access the doctor. We saw a tremendous reduction in no-show rates. I think some of the questions that emerge from the role of telemedicine in the future will be sort of, can we do, what can we do with just a video? And what can we do with just the phone? I found that there wasn't a huge difference between phone and video. And so I think time will tell and we'll get better at it, but the reimbursements of those things have to parallel the care we're providing. And I think then we're broadening access in a way that I think will impact equity for years to come. That's one of the things that I think emerged from the pandemic. I think the other thing was just creative programming. We were able to set up a virtual call center where we addressed socioeconomic needs that were exacerbated. We were able to watch and get buy-in from all of the CMOs to have COVID-related equity dashboards monthly and weekly, and then sort of address any gaps in care provision for patients admitted to COVID in real time. So the health system had an appetite for it during the pandemic. And the question is, how do we sort of translate that into stratified performance metrics moving forward? One of the things that I noticed that was really telling, as well as when you reduce the constraints on the insurance barriers, which we did, right? So we paid for everything. You had more timely access to care, and you had more immediate access to care. So that was another thing that reduced inequity during this time. And so we did not see differential mortality rates between any of our racial and ethnic groups across our downtown hospitals. So we provided high quality care by eliminating access barriers.
Great. Tina, you mentioned COVID in your intro talk with Matt. Are there some things you saw in Harrisburg, either positive or challenges, that you'd want to talk about to add into this conversation? I think you might be on mute.
Yes, I agree with what's been said. And I think, we have to be nimble and fluid to be able to provide services to our community, and, doing things very deliberately about making sure you had interpreters at some of our vaccine clinics, making sure that folks, we had the A1 groups with the 65 and above. And a lot of times when we design programs, we think, oh, well, just go to the website, or, oh, just call this number. And realizing, like, a lot of the folks in the A1, they didn't have technology to do that. So we had to go above and beyond and actually call some of individuals to make sure providing transportation to some of the sites were very critical. And also understanding that healthcare systems can't do it alone. Working with your community partners, we were able to help facilitate and map out for our cities and counties within our footprint how to respond to individuals who were homeless, who were impacted by COVID. Again, it's not a one size fits all. And I think representation at the table when making these decisions is so important. And that way you don't have to go back and redo some of the work you've already done, because guess what? Oops, we missed someone, or we missed something, or we didn't think about it. So, when it comes to diversity, equity, and inclusion, it is so critical that you have that diverse representation at the table that can be the voice for those who are voiceless.
Let me ask you a follow-on, Tina. I read that you guys have a program called Healthy Harrisburg that offers resources for people who are facing chronic illness and lack adequate access to the healthcare system. Can you just talk about that effort a little bit and who you partner with and how?
Absolutely. That was my baby, and I'm so excited about it. So, Healthy Harrisburg is a program. It's a fitness program, education program, specifically designed to address chronic disease in communities of color. We looked at our community health needs assessment and looked at where the chronic disease and the disparities were. And we were deliberate about engaging populations that had diabetes, obesity, and hypertension. And what we did is went out and started these groups, education groups, and fitness groups, and making sure that the people that were leading our certified fitness instructors represented the individuals in those communities. And because of COVID, we started this before COVID, and we thought we are going to have this big celebration and kickoff and everything, but we had to go online. So we were intentional about doing things online, doing things in, we have a large Latino, Hispanic population. So making sure that we had individuals that were able to speak the language of the individuals that were signing up. This is actually a 3-year pilot.
We just lost your.
Yeah, Tina, you muted it. Ended up muting yourself again.
I don't know how that happened. That's because I moved my hands. I'm going to sit on my hands. We where did I stop? Baseline.
Well, you had mentioned that this had to go online, and you made sure you had the interpreters for everything and people speaking Spanish. But so now is that going to maybe go back to in-person things going forward?
We just did our 2nd-year kickoff at City Island this Saturday. And again, with social distancing, we have a space that's big enough that we can have classes, and we'll do a combination because it's not only physical, we do education around heart disease, mental health, racial trauma, self-care. There's so.
Oh, you did it again. Muted again.
I'm having challenges this morning. I
That's
apologize.
okay.
I don't know what's going on here. People don't want me to talk because I talk too much. No, but it's a great project. We look to replicate it across our footprint, and we can see the needle moving. So the 8-week cohorts, and really engaging and connecting people to each other, and creating that support system. We can see the needle moving. People have lost, since we began, 10, 15 pounds, gained muscle. Some of the numbers have gone down. So we're very excited with this project and hope to continue it.
That's great. Thanks. Aswita, let me turn to you. Mass General has been doing this disparity reduction work for more than 10 years and makes its results publicly available. Could you talk about what it's built into its workflows, kind of to make this part of the muscle memory, and some of the challenges the organization had to overcome in collecting accurate racial and ethnic data from patients, and then to be transparent about it in sharing dashboards?
Sure. So what David's referring to is we have an annual report on equity and healthcare quality. Actually, this year's report looks like this. I happen to have a copy. And so as you can see, it's a 50-page report, and it really takes all of our quality metrics and stratifies them by race, ethnicity, and language. And we've been doing that over a decade. And I will just say, it's obviously work that's taken a while to get to where it is now, and it takes at least a year for our team to put the report together. But in building this report, what we've really done is socialized within our institution, looking at our core quality metrics for disparities. And with socialized, I mean, you have to get leadership buy-in. You have to be able to understand the data that you see, interpret it with the clinicians, get their input. And then, you know, it's gotten to a point where like our board expects the report. We've gotten a lot of awards for it, but I think most importantly, it was very helpful in building the infrastructure in our system that we can look at our quality metrics very quickly and very rapidly. So we were actually able to translate this during COVID by setting up a dashboard to look at our patients who were in the hospital by race, by ethnicity, by language needs, and by zip code to see where they were coming from. And we knew then very quickly who our patients were and what were the needs that we needed to sort of tweak in our system. And if you look at a lot of the COVID data, even by state, you will realize that a lot of that data is missing. And so they can report on a part of it, which is still better than nothing, but not all of it. And so we've done quite a bit of work. I will just say, like, you know, it took time for us to get there, and that includes sort of the basics of training the folks who ask the question, making sure they have scripts, making sure that we tell patients what we do with the data, who sees it. So again, this whole addressing the privacy concerns that people have. And then also checking that the data is accurate. So not just making this assumption that we train one and done. And then really like making sure that we continuously have an improvement process on our data collection. And then I will just say lastly, what has been really important is to understand the terminology changes. And so we've certainly seen that. And this year, we didn't get to do it because we were already in production by the time we got it. But I know that we've changed a lot of the terminology in our reports. So we say people of color versus minorities. Next year's report, what we are aiming to do is really be thoughtful about how we present the data. And so not making white folks always the reference group. And so those are like, you know, next level things, but also even understanding that like the terminology changes constantly, how people self-identify changes constantly. Certainly when you look at the LGBTQ data, you can see some of that, and we just have to be flexible with that. But at the core of all of this is knowing that getting some data is better than having no data, which is the baseline for a lot of this country. So you know, people always get really into that, like, but my race is not on here, and how do you rule it up? And I always say, I get it, but don't let the perfect be the enemy of the good. You got to have something. You know, that's sort of visionary. But like, let's just get to step one. And so that's, I always like have that like sort of like reality check. Our CMS data is incomplete. Our Medicaid data is incomplete. Let's work on it.
Okay. Chahaya, could you talk a little bit about promoting diversity among the health system employees, clinicians, leadership is connected to making progress on health disparities among the patient population?
Sure. I think Tina and Shveta probably could chime in on this as well, as they've referenced it in their answers already. But essentially, I think diversity and inclusion is integral to achieving equity. And in some ways, it's its own strategic intervention. And the reason for that is when we think about the forces at play that create inequity within a healthcare system, it's the way structurally or institutionally our healthcare systems are designed, and baked into that design has been historically a single cultural perspective. So they've been designed predominantly historically by one culture, oftentimes by one gender, and that's been predominantly a white male perspective. And when you design a system with that singular perspective, baked into that system is a lot of bias. And that bias is set up in a way, unconscious and unintentional, to disadvantage multiple other perspectives and cultures and backgrounds while advantaging one singular culture or background. And so diversifying the workforce has to happen to address structural bias and institutional bias. Not only has to happen on the front lines of who delivers care, but actually it has to happen at all levels of the organization. So from the front lines to those that are designing the healthcare systems of tomorrow, and those that are also generating the medical science of tomorrow. So if our scientists aren't diverse, if our health system leaders aren't diverse, then you're going to continuously have an institutional structure that is biased and advantages one group or another. The other factor is a micro level factor. So you have the macro of institutional bias coupled with interpersonal bias, right, at the provider level. And the provider level biases oftentimes are mitigated to a certain degree if you have race or gender concordance. However, not all of it is. And the reason is because we are all acculturated into that larger system. So we're all still learning that biased, irrespective of our own identities, we're still learning that biased medicine and operating in a biased system, which is why it's so important that diversity goes through all levels of the organization, as well as all sectors within the organization.
Your Center for Health Equity Advancement is located within the Office of the Chief Medical Officer. Could you talk about why you felt that was important to have to be situated there?
Yeah, and I think, again, Tina and Shweta has probably alluded to this in their response. I remember Tina saying this is not a one-person job. Equity is not a siloed activity. It's integral to your daily operations. And we wanted to send that message to our health system. And so we wanted the center to sit in the C-suite. We wanted to be at the table of all sort of CMO, CNO, and CEO discussions, because you don't know what problem could be an equity problem. Everything could be. An equity lens could be applied to everything we do. And so if you silo that activity or shoulder it on one organization, sort of, or one niche spot within your organization, you are missing something. And so our center is uniquely situated in that regard. So we have a say in everything that goes on to make sure there's an equity and inclusion lens applied to it.
Tina, you mentioned in your talk with Matt that you were relatively new to healthcare, just 5 or 6 years. Was there, you think there was a value in bringing that outsider perspective a little bit? Was there anything that surprised you about the culture of coming into healthcare and trying to make these changes? A benefit from coming from the community-based organization world into healthcare?
Absolutely. As we all do when we're transitioning careers, and you do your research. And when I researched healthcare, I was so excited that healthcare talked about cultural competency and making sure that patient care was the focus, and providing all these resources. And coming from an organization whose mission is empowering women, eliminating racism, I thought we can start addressing the root causes of some of the things that take place. I'm going to be honest with you. The first year and a half, I thought I was on candid camera. I thought somebody played a real joke on me, because I started asking questions. Where's the data? What are you doing here? And they would say, we have the strategic plan. And I'm like, yes, but what have you moved it? What's been done? And so I was fortunate enough to take the strategic plan to another level and really start putting action behind it, and really creating safe spaces for our medical staff to ask questions of different cultures around how do we care for you better. I was able to do that with we have a large Nepali Bhutanese community here, bringing the leaders into, the hospital to say, hey, tell us how we can do better. Tell us what we did wrong and tell us how we can fix it. We did that with the Latina Hispanic community. We did that with a Muslim community and a lot of our faith-based communities, bringing them, asking them questions. I think it was important to create that safe space so people could feel comfortable in asking questions. A lot of times we do these presentations with these white little PowerPoints and have all these words up there. That's not really sinking in if you really want to connect with people. Yeah. And I think from that, you build that trust and respect in your community. Tell us how we can better care for you. And so those were some of the things that we were able to do, especially with our LGBTQ plus community. That was so important. When I looked at the data of our community and how they weren't seeking out care because the way they were treated, I was like, oh no, not on my watch. This is going to change. And I'm going to tell you this, that was an uphill battle, because where am I? Central Pennsylvania. and just think of the dynamics of central Pennsylvania. And when I said we're going to do SOGI, we're going to have the Health Equality Index, I thought every night I walked out to my car thinking, who's going to get me? And it wasn't about anybody from the community. It was like, okay, who is not putting up with this and has had enough with me? And so I think we moved along and people are starting to get the importance of it and how diversity is not just singularly focused. It really encompasses the diversity that we all bring to the table. And as healthcare systems, we're responsible for addressing that.
Great.
Was I on mute? I wasn't on mute.
That was fabulous. Aswita, could you describe how the Disparity Solution Center works with other health systems? Are there some common issues or roadblocks that champions of these efforts run into when they're starting to get these established? What do they need help with most? Funding, leadership buy-in, or ability to gather the data? What's the things that they come to the center looking for help with?
Yeah, so this is our Disparities Leadership Program, and this is a program that we put into existence because, well, we couldn't really clone ourselves. People were asking us for help, and so we said, well, let's just build a program that people can participate in. It's a one-year program, and it's a mixture of, it's a hybrid program, really, in-person meetings and then remote sort of, video calls like this. And I think the number one thing that people have to have a project that they move throughout the program. And I think the one thing that we've learned in like 13 years of doing this program is the foundations are still the same as they were 13 years ago. You have to have data collection, you have to have leadership buy-in, you have to monitor and report your data, you have to work with community. But I think what has fundamentally changed is, people would do a lot of the work and then they would come to me and say, oh, well, I was successful in implementing X, Y, and Z, but somehow I feel like we haven't really crossed that threshold. And really, that's when you take a step back and look at sort of the Cotter model about what does it take to transform your organization. And the Cotter model is very clear. He's a Harvard professor. In what are the 8 steps that it takes, and they're sequential. And when you read his book and with the lens of disparities, you realize all of a sudden why it feels like though you've accomplished a lot, the organization itself has not necessarily transformed. And it starts with like a vision and then communicating the vision. So I think that's very helpful to think that you can accomplish many things, but to transform an entire organization to think like Jaya says, like with an equity lens from the beginning, it takes time. And it takes a lot of things. And so it is a long journey we're on. And then people always ask me, well, how do you know that you've achieved equity? And I always say, well, it's kind of like quality, right? Safety is like, it's a goal that we have. There's always going to be things that aren't going to, be safe, but that is a goal that we're heading towards. And we have to keep that in mind. And equity is the same thing. Like we'll never really be able to say, oh, we're here, we're all done. But I think that is a vision that we have. And in the interim, we're on sort of this journey that is very complex and goes beyond our institution. It's about like acknowledging our history, our country's history of how we've dealt with people of color or other communities. And then consequently, what are the systems that we built to keep that system in place? So.
Are there some issues that health systems have, just base level problems gathering the data?
Yeah, I mean, the thing is people say, show me the data, right? Like when you try to highlight a problem, people are like, well, show me the data, show me the research. And so a lot of organizations don't necessarily have reliable demographic data. And so that is probably the first challenge. But I always say, like, you could take any data, stratify it by race, ethnicity, even if it's like a small amount of data, put it up on a slide, put it in a boardroom, and you'll have a discussion in a way that you won't have if you just talk about this is what we should be doing. Mm-hmm. So data is very helpful in highlighting that, but what is great is if you can complement it with a case study or a personal story, that brings the data to life. So the combination of the two is what we need. And I will just say organizations, they want to go straight to the sort of sexy intervention that changes outcomes. And then they sort of misstep the fact that they don't have the data foundation that they need. Like you still have to do all that hard work of making sure you have that.
Can I just
Yeah.
add on something that she said that's so critical, especially in healthcare, is that a lot of healthcare workers seek to solve the whatever issue it is quickly. This work cannot be done quickly. And there are a lot of type A's that want a solution that lead these healthcare systems. And you have to reinforce that it takes time. And I think what you said was so brilliant. And we need to understand that it is a journey. It's just not a destination.
Okay. Jay, I think when I talked to you before, you mentioned a few ways that you're seeing this as an avenue for research as well, like within your own health system. Like I think you were talking about a way to measure wait time disparities and use that as a way to make changes within the organization. Can you talk about that?
Sure. Again, I think Aswita's comments resonated with me as well. I almost want to double down on that as well before pivoting.
Sure.
No, it's like I wanted to jump in at the same time and say, oh my God, okay, this is exactly the statement that needs to be underscored. I think, the culture of equity and creating a culture of equity has to mirror like decades of voices that have been talking about the culture of quality and safety, which is it's iterative, it's long-term, it takes a lot of time. You have cycles of innovation where you reflect, you study, you do, you act, and then you reflect again, and then you study and you act. And equity is no different. This is a long-term iterative process that requires similar strategies to quality improvement, but incorporating the community and patient voice into that. So you have a diverse cadre of stakeholders, working collectively on that plan, do, study, act cycle that you institute with quality improvement. So similarly, some of the research that we're bringing to the forefront, oftentimes when we talk about equity, we either talk about it in a small intervention like randomized controlled trial or pre-post intervention, sometimes, as Aswita alluded to, that sort of jump steps the defining the problem really carefully and just skips over that part and goes right to an intervention and you test it. Or we have these frameworks that are at the 100,000-foot level where we're just talking about the principles of how to go about. We want you to do this in a large scale way, but there's a whole, like everything from the 100,000-foot level to the 10-foot level, there's a whole slew of things that are missing about how organizations can understand how to operationalize these principles in action, like a true roadmap, like of how to. And that's the sweet spot where our research lives, because really it's taking that 100,000-foot level and translating into really pragmatic strategies on the ground. And so one example of that is when you find and identify a disparity, and I'm sure the Disparity Solution Center has done stuff like this in the past, but how do you shepherd a project where you analyze, well, what are the root causes of that disparity? What are the potential countermeasures that we can develop? And how do we test those countermeasures? So we had an ED wait time throughput disparity within one of our hospital systems. And so it used to be a routine CMS measure, which may have been sunset in the last year or so. But essentially, it's for admitted patients only, non-trauma patients, where non-Hispanic Black patients were waiting on average 76 to 80 minutes longer than a white patient to be found a bed. This is after an adjustment attenuated that difference. So if you adjust for insurance, conditions, what they presented with, their admitting floor, whether they saw a same-day physician, whether they had a same-day visit, the number, how crowded the ED was during that time. We adjusted for all of those things. Their triage score and rating, their several factors, but you adjust for all of that, it attenuates the difference, but there's still an independent race-based difference. And that's important because sometimes we talk about risk adjustment and we say, okay, it's good, we've risk adjusted it, the problem's gone. No, in the reality, the problem's not gone. The problem is still there. The people are in reality are still waiting just as long as they were. Risk adjustment helps you understand the root causes of the problem. It doesn't eliminate the problem. And so we found out, we narrowed into what the problem was through multi-level modeling and a lot of risk adjustment. We also process map, which is the first step. It's a quality improvement step. From the patient's arrival to the patient's time and just to admission, to figure out where along that pathway that disparity lied. And we narrowed it down to the time period between when the provider sees the patient and when they call for a bed, which was actually not where we thought it was going to be. We thought it was going to be a triage, but it wasn't. So really important process. And then we did a lot of robust sort of qualitative inquiry observation, where we observed for 2 hours straight providers and patients in the area where the disparity was occurring, and semi-structured interviews with patients that were admitted as well as providers to figure out some of the root causes. And what we found was really, really interesting. And I don't want to take up everyone's time, but the process of discovering that is that applied process and what we wrote about. I can name a couple of the themes if we have time. I don't want to like,
just go ahead if you can, very briefly.
Okay,
I
fine.
think this is interesting.
We found 3 themes that were important. We were able to actually stratify each of the ED physician's own performance scores, but we blinded that to all the study analyses, and we only unblinded it afterwards when we analyzed patterns in the data. And what we found was that providers, when asked about what may drive disparities in wait times, the vast majority did not name race. They used other code or racially marked language that you could infer as race, but they avoided naming race. And there was only 3 times race was mentioned, even though every other demographic was listed as a reason for disparities in wait times. There was 3 times race was mentioned. The first was to say, even though it wasn't prompted, I don't think race is the issue here, by one of the providers. The other 2 times it was mentioned the way we would have expected it to mention, that there are biases that cause race. When we unblinded it, the providers that named race were the only providers without wait time disparities themselves in their panel of patients in the last 6 to 12 months. Naming race is a critical intervention. Strategic colorblindness perpetuates inequities. So that was a key theme. The other one was the reliance on triage scores. So ESI is an emergency severity index, and the providers that named objective criteria for triaging their patients and prioritizing patients, including ESI, were the only ones without wait time disparities. So there's structured processes, and naming race are 2 key themes that emerged that were important.
Great. Sweeta, did you want to weigh in on this?
Yeah, so I had somebody ask me one time, it was a chief, I think, and he said, can you just tell me like what intervention would solve all these problems? And, I kind of was like, but I actually realized, and Jed, I think your example highlights this perfectly, is any improvement that can take out unconscious bias would probably be worth exploring. It's not going to be in your quality metrics, right? So, but this whole idea of like unconscious bias is what tends to lead to the disparities. We can do a lot of systems changing, but until we do something that addresses unconscious bias and allows that to take that unconscious bias out of the decision making and the assignment of either beds or what we found like beds that are in the hallway versus in a room, or in the ED, like the use of restraints, all of those things are probably due to bias about who you think should get what. And if you remove that, or if providers, like you noted, are aware of racial disparities due to bias, they can prevent that from happening, be more conscious about that, be more thoughtful and deliberate. So I think that is really something that is difficult to dig through in your quality metrics, but likely any improvement that you do does need to address that to work. So I ended up having an answer for him, but when he first asked me, I thought, oh my God. You asked a $5,000 question, sure.
Let me ask, is there anything that we need that could help as far as payers doing more to incentivize equity, Medicaid managed care organizations having metrics around how health systems are doing, kind of to hold health systems' feet to the fire? And the CMMI has all these alternative payment models. Could there be some that are focused on these issues? Anyone have a thought on that?
I'm on some work group that is looking at alternative payment models, and we only had one meeting, but I will just say it's tricky, right? Because it doesn't necessarily address social determinants of health and the things that sort of happen outside of the institution. So I think I've always pushed that that the only way that organizations are going to move towards like implementing data collection, become accountable, is if we have large bodies, federal and state bodies asking for that and holding folks accountable. But there is a lot of resistance to that, because you get into this whole thing about who is the population that I serve, and I don't want to that whole thing about pay for performance. I don't want to be penalized for serving a population that has more needs. So we have to be really thoughtful and deliberate, and I think this is still a work in progress. But I honestly, until these regulations start addressing it, and the Joint Commission's looking at things like that, most of the organizations will take a pass. There's something else that is more burning that they would rather put their money or they're fired, put the fires out. So.
Okay. Yeah.
Yeah, I would like to add to that. I think as Shweta said it right, the devil's so in the details of this. So I think not only do you have to worry about, is there a scope to do this? Absolutely. The easiest way to do it is take our routine quality performance measures that we incentivize hospitals for and just say, stratify it and show us how you do by subgroup. And sometimes that can help them improve their aggregate quality metrics. So there's a benefit to that, at least doing it internally. When you start to link that to, as Asuda said, to performance, I think what you worry about is, are we recreating a problem where we're going to have people cherry picking and constraining access to improve on those performance measures? And that's something we have to worry about. And are we also sort of penalizing hospitals that serve a greater proportion of folks that have faced structural inequities and thereby are more likely to have issues moving the needle on those metrics? And so I think it does have to be done thoughtfully and done in a way that allows us to not sort of penalize hospitals and health systems that are serving the most vulnerable in the process.
Right. Tina, do you want to weigh in on that?
I would just say ditto. I think one of the important things is, and Jai said, you have to call it out, but also you have to do that, what I call clean your house, to make sure that your providers are educated and do that self-assessment and know what they're bringing to the table in order to make this all work. There's a lot of little details that go into this, but understanding and calling it out is so important.
Okay. Tina, you mentioned the phrase community health workers. You said your mother was a community health worker before the phrase was even invented. Do those kind of programs, health system navigators, social service referral networks, are they really have a lot of potential to help improve disparities, or are there limitations to that kind of approach?
I wouldn't think there are limitations. I think they are a piece of the puzzle. as we put all these things together. I wouldn't say it's the end all, the be all. I think, again, when you talk about building trust, especially in communities of color, I think it's very important that, we have community health workers that are out and about and a part of the community, helping to address some of the social determinants of health that impact people from receiving quality health care. So I would say it's a piece of the puzzle. And I think it helps with navigating, especially, patients that have multiple illnesses and challenges. So having all those pieces together is very helpful, especially with that top 5%, and making sure they're connected to resources that we're not able to provide in the healthcare system.
Anybody else want to weigh in on that one?
Yes, I agree actually with Tina wholeheartedly. I think Tina's already talked about the important role community health workers and patient navigation individuals can play, or especially community health workers, in terms of acting as a way in which the health system can get the community perspective to redesign themselves to better and improve their access and their cultural effectiveness. I think it's a piece of the puzzle, just like she said, and it cannot be the only piece. And I think it's important for health systems and providers to get the right message about why patient navigators and community health workers may be needed in this moment. And that is, there is a system and provider-based deficit that they're helping bridge. There is not a population deficit that they're helping to bridge. And that is an important thing, because if the take home is this population is somehow lacking in some way and needs this extra layer of assistance to navigate a perfectly poised healthcare system, then that's the wrong take-home message. The take-home message should be our health system is broken, and therefore extra layers on top of it that help us better serve a broader swath of the communities needed in the interim, while we figure out a way to make our healthcare system less complex, more culturally effective, and more inviting to a broader set of stakeholders in terms of access and uptake. And I think if that message is happening simultaneously with these sorts of interventions, then it becomes like an important message, because I think if we see it as the end and not a stepping stone towards a greater solution that involves structural and system change, then we will be only applying a population deficit intervention and not a systems deficit intervention.
I think that's an interesting point. We have a couple questions from the audience I'm going to turn to now. One person says, much of the discussion so far have been talking about physicians. And are there differences in data when you're talking about nurse practitioners?
So I saw that question, and I just want to say, when I say clinicians, I mean both physicians, nurses, midwives, everything. But I will say that there's been a lot of focus on increasing the diversity of the clinicians and not so much focus on the nurses. For the large part, when you look at the data, and the nurses are patient facing. So even when I think about patient satisfaction surveys, I think the nurses play a key role in making sure that our patients feel cared for, that they score us high on all those metrics. But I'm not sure that we're doing a good job in sort of addressing their needs, and also like increasing the diversity. And this kind of goes down back to like making sure that we help students think about nurse as a career. And I will just say that this is a challenge, and I think we're still working on it. And I think that you probably see a lot of the similarities in the data from the nurses as well at the end of the day.
Go ahead, Tina.
And I agree with you 100%. I think it's so important that we create our workforce pipeline. We have to do that ourselves, especially when it comes to community of color. I say this all the time, and I truly believe it. If students of color do not see people like them in certain positions, they feel that those positions aren't for them. So they won't seek out to become an MA, a nurse, a doctor, what have you. We have to be deliberate about going out into the schools and really exposing students to the multitude of careers in healthcare. And I think we have to start doing that. We should have started doing that probably 15, 20 years ago, knowing that we're going to have a gap. But we really need to be more deliberate about doing that. And also looking at, when you talk about systemic racism, looking at our medical schools and making sure that it doesn't take 20, 30 attempts for students of color to get into medical school and be able to graduate because of all the barriers that have been created. So again, there's a multi-levels, multi-intersections. It's not a one-size-fits-all, but to acknowledge it, to call it out, and continue to work on addressing it is very important.
Okay.
I would love to add to that too.
Yeah.
I think recruitment's like a revolving door, and you can improve the pipeline, but if you don't set up the system so there's equitable advancement in the organization, equitable evaluation at the front lines, then you're not going to retain and you're not going to advance. And so all of them are important. And actually retention and advancement, one would argue, can be more important because then it begets recruitment down the line. And I think Tina also alluded to that in her conversation. I think what we see at Penn, and we've had these conversations. I really appreciate what Ashmita said about the diversity in all of our workforce. When we look at Penn and Penn Medicine in the downtown hospitals, we have a unique situation where we have no racial and ethnic majority in Philadelphia. It's about 45% non-Hispanic Black and about 40 some percent non-Hispanic white, and then less than 5% is everyone else. So we really don't have a racial and ethnic majority, and the only group within our hospital in terms of workforce that reflects the community we serve is our MAs. But we don't see it with our RNs, and we don't see it with our NPs. And people have never thought about MAs as a natural transition to an RN or an NP. And we've had dialogues about that, because why don't we? Folks that become a medical assistant, they care to do a similar type of job. They may not have the money to go to a 4-year nursing school or have the time to do that. So how do we create opportunities, or how do we create advancement opportunities with positions that do reflect the communities we're serving? Similarly, with community health workers, are there some of them that want to become social workers, that want to get that advanced degree and actually transition into being a healthcare professional within the workforce? And because they automatically reflect the folks that the community that we serve, yet our social work landscape does not at all. And so these are the sort of anchor points. How do we create opportunities with folks that are already in our healthcare system walls to advance them within the organization?
Ashmita, did you want to weigh in again?
Yeah, I have this analogy that I used last week, as it's a personal analogy. I have 2 daughters who are in soccer, right? One is 15 and one is 9. And I signed them up for a soccer camp in Harvard. And, it was so interesting. I think this is very relevant to sort of the pipeline. There's club soccer, which I'm not going to spend thousands of dollars and drive. I don't have the time to drive my kids, across the state of Massachusetts to go to club soccer. But it is the premier way to get training, right? Is to have your kid in club soccer. So my kids do town soccer, and then my oldest is in a varsity soccer at a public charter school that's very diverse. So I'm filling out the application, and it starts with, what club is your kid in? I'm like, none. She's in the varsity, level. She's in 7th grade, but she's not in a club. And And at the very end, and like about 20 of the questions were about club, without acknowledging the amount of money and resources and time it takes for anybody to do that path, right? And that there might be something else open to other folks who don't have, and even just doing town soccer takes time and effort. And parents have to have cars. So we've definitely found that out when we were sort of recruiting. And at the very end of the application, there was this question that just sort of was like, do you know any Harvard alums, or are you a Harvard employee? And I was like, why is this relevant? And I was like, no. But this sort of, to me, speaks a lot about how we've built these systems that reward people that have access to a lot of resources. And hey, great, you are in a club. Which is a club? What's your coach? What is your status? And we have something similar in the medical education. We don't acknowledge those folks who don't have the money, they don't have the time, they don't have the resources, they don't have the parents who can navigate like a Harvard application online. Like, there are so many things in this that we are sort of not saying. And then we have this bias that all soccer players come from certain cities and states and schools, right? Without thinking about how we got fed into them. So anyway, that's, I've been asked to do the D&I recruiting of the town soccer. So I'll let you know how that goes. But
Okay.
that's the first thing I said to him. I was like, that application is so problematic.
We had another question from the audience, and as we mentioned this briefly, but the person says, what's the role of technology to address social determinants? Will it really lower costs, since about 30% of rising sick care costs are due to technology? I'm not quite sure what they mean, but anybody want to
I mean, I do think it solves a lot of the problems that we had identified for populations like, transportation, the inability to take time off work. But we do have to be thoughtful that we aren't then turning around and creating other gaps. Like, so, this whole issue about like virtual visits, video visits versus phone visits, again, I was like on some video visit with my pediatrician, and she wanted to look at my daughter's sore throat. And like, while my daughter is like, close to the camera and her mouth open, I was thinking, I don't know how this would work as a phone call, right? And would we get the same kind of care? So we have to really think about that. If the majority of our patients who need an interpreter end up being on the phone because our systems can't accommodate a third party in the video visit, that's a problem. Right? Are we okay with lower quality of care for certain populations? And I would say, good quality care, without equity, there is no quality of care. We're not. So I think we just have to be really deliberate and thoughtful about the systems that we build. But yes, they can address many of these issues that formerly patients, like had challenges with coming in on site, traveling over here, taking time off work. But there's other things that pop up that we have to think about.
Great. I want to close with one last question, and it's about the sign that's right behind you that says, do the right thing, get uncomfortable. Why is that? Is it uncomfortable for a lot of the people to work and be anti-racist? Is it uncomfortable for a lot of people to work on these issues, and how do you help them stick with it, even though it might feel uncomfortable? And maybe all three of you could talk a little bit about that.
Yeah, so this is a poster board from last year when we did a kneel-in for Black Lives Matter, and I just kind of had it in my office. And so it's funny because now it's like it's in my Zoom background. I do think, my number one recommendation to everybody is get comfortable being uncomfortable. We're going to talk about some really difficult issues, and you have to do the hard work yourself, on yourself first, before you start asking MGH to make changes. I would ask back to you, have you done the hard work? Have you looked at your own bias? Do you talk about microaggressions? Do you make the environment friendly on your team to talk about these issues? Because that's what it's going to take. And so that's sort of my takeaway is like, and don't let the perfect be the enemy of the good by saying like, I don't know what to say. It's like, well, you not saying anything is also a message, and it's not a good one. So saying something is better than saying nothing. You're going to have to keep trying. I think all of us who've been doing this work know from years of experience, students will still be students 20 years from now about how to talk about this.
As we wrap up,
Yeah.
anybody else want to weigh in? Jaya?
Sure. Oh, go ahead, Tina.
Go ahead.
No, I would just, I would add, I mean, I think Ibrahim Kendi says this as well, but racism is like the only problem we've tried to solve without naming it. And again, like, you know, our findings find if we don't name the problem and define the problem and talk about the problem, that is the first step to perspective taking. That is the first step to many of the bias mitigating strategies, is understanding that there is a problem, making your unconscious bias more conscious to you and making it more conscious to the system at whole. I also want to, I'll defer to Tina, but I also want to come back to say, we also have to push and get more comfortable. We have to get more comfortable. I'm just going to use this to like answer some of the tech questions that I wanted to like say for the last question you raised, which was, there is a lot we can do with tech if we're willing to go there and really understand the limitations, but understand the promises. I mean, I think the best example of a technology that has catered to the masses is the iPhone, right? Irrespective of culture, background, et cetera, it's opened up its barriers, and we can make our technology more nimble and more, you know, culturally effective for all if we kind of really lean into the root causes of the problem here, which are structural bias coupled with interpersonal bias, and how we can broaden access in the largest stake of the world by including other stakeholders.
Tina, did you want to weigh in?
Yes, I think both of you ladies said it very well. And I'd say, you know, self-awareness is about making time to reflect and examine on your own experiences. And I will say this probably until I'm unable to speak, but we have to begin to listen to understand instead of listening to respond. And again, I think it's important to do your homework. Don't expect someone else to do it. And I get this all the time. I'm afraid I might say something that you to offend someone. Hell yeah, you are. Excuse my language. You're going to. But you got to move past the fear and continue to have these conversations. That's the only way things are going to change. So again, and I agree, you know, silence is compliance, and we can't be silent anymore. We have to speak up and speak out.
Okay, well, I want to thank all of you. This has been a fabulous panel. It's been a real treat to get to hear from all three of you. I'm going to turn it back over to Matt now to wrap up, and we're going to move on to another panel in a few minutes, I think.
Thank you, David. Yeah, I want to echo that. Excellent opening discussion and panel. A big thank you to our faculty. We are now on a very brief break, and we'll be resuming our virtual summit at 11:45 Eastern Time with the Fireside Chat Cybersecurity Expert, Micro-Segmentation, and Zero Trust. So we look forward to seeing you all back on here at 11:45. Thank you very much.